So at the conclusion of this program, we just wanted to have one take-home message for the people in the audience. The ophthalmologists are the first point of contact for any child with visual impairment. So when the complaints of the child and the complaint that the parents have are not matching with our findings, then we have to keep CVI in mind. Any child with even minimal disability, please anticipate vision problems. Having a visual skill questionnaire handy is very simple and easy way to manage these children. We have to talk to them about early intervention, therapy, and overall development. And please do not say that nothing can be done. Once that nothing can be done is imprinted in their brain, it's very difficult to get that idea out of their head that something can be done for these children. Thank you all.
Perhaps it's a very important subject from the um, management point of view, both from the patient management and the hospital management point of view, because it can reflect on what you need to do as an emergency immediately after the event has occurred, as well as to prevent such relapses in the future. So this is a discussion on cluster and ophthalmitis, both clinical management and also the circumstantial management. We have a few didactic lectures on the subject, followed by a panel discussion which will be moderated by Dr. Padma Pal. May I request Dr. Anika Amritanand to give the first talk on cluster and ophthalmitis, an overview and investigation. Before we proceed, the chairperson was supposed to be Dr. R.D. Ravindran. He is held up in another session and will join us shortly. Dr. Anika. Dr. Anika is the professor and head of the outreach services in the Department of Ophthalmology, CMC Vellore.
Respected Chairperson, panelists, and friends, it's an honor for me to be giving this talk today, and I'm grateful to the Vision 2020 Scientific Committee for giving me this opportunity. Cluster endophthalmitis is a horrific nightmare for the patient, the surgeon, and also has far-reaching consequences for the institution as well as the ophthalmic fraternity at large. And if we need to control this beast, we need to know about it. We need to recognize an outbreak when it's occurring, investigate it, and also in our normal day-to-day practice, have a continuous documentation and surveillance system so that we can pick up outbreaks. What happened? Sorry, something. Yeah. So cluster endophthalmitis it usually arises in an OT or sometimes not even an OT circumstance because of a common source of contamination. It occurs in more than one patient in an incidence which is much higher than what is the normal sporadic incidence. The organisms are mainly gram-negative or fungal, as compared to sporadic, where the commensals or patient-related factors are most common. This is a review which just kind of shows, I've just put it there to highlight the myriad places from which a patient can get infected. Could be anything which comes into contact with the eye, as well as the common pathogens. Intraocular solutions have been the culprits in most studies. However, this could even be because they are the most amenable to a microbiological evaluation and not just that needs to be analyzed further. Also to note that sometimes you may not even have a source, you may not even identify a source around almost 50% of the time, even if you investigate. The second thing I want to bring out is the changing trend in cluster endophthalmitis. These are some recent studies from India, and we see more and more clusters being reported after intravitreal injections. Newer organisms which are emerging, and also highly resistant organisms which are emerging, and that needs to be a caution to all of us. Now, what is important is to recognize an outbreak or a cluster from what is the normal, regular endemic rate of endophthalmitis which we may experience. The AIOS and ESCRS guidelines say that when 2 or more cases operated on the same day in the same operation theater, that constitutes a cluster endophthalmitis. That is easy to recognize because if you have 2 or 3 cases occurring on a day, you obviously know that something is wrong. But what is important is to realize that cluster endophthalmitis can occur over days and weeks, and it's important to recognize it from a sporadic outbreak. And a general definition for that is that the incident rate is significantly over than what is expected. So how do we start recognizing an outbreak? The first patient of endophthalmitis we get, we need to determine whether it's an endophthalmitis or a TAS or an increased postoperative reaction. And if it's an endoph or a TAS, both of these need a proper investigation to find the cause and to mitigate it. Each of the cases of endophthalmitis needs a proper review and documentation for the patient factors, pre-op, intra-op, post-op, as well as the environment and surgery-related factors. So when do we start thinking there is an outbreak? If there is a common organism or source which we are finding related to each of those cases, obviously more cases in less number of time, and a rate that is significantly over that is expected. From a current review, our country rate is around 0.08 to 0.16, which is around 1 in 1,250 to 1 in 625 infections. We have statistical methods which help us find a balance between complacency and panic. So this is a table taken from a very hallmark publication which has been used by several guidelines to guide determining whether there is an outbreak and what our action should be. So this is a probability table which tells us, keeping a sporadic rate of 1 per 1,000 surgeries, as to how many number of cases are expected within so many number of operations. So these numbers are actually probabilities, and this gave us the classical traffic light system, which says that if the probability of your infections is less than 0.01% of happening at a sporadic rate, that is your indication for an emergency. You stop surgeries, you form an expert team, and start a full-blown evaluation. There are other methods which you could be used depending upon your milieu, depending upon the number of cases you operate. However, the take-home point is we need to be vigilant and actively monitor our incidents because clusters have been known to even occur over months. So if an outbreak happens, then what do we do? So basically, it becomes an epidemiological exercise, just like the first one by Dr. John Snow, who found the source of the infection in a hand pump. So we need to find our hand pump for our cluster of cases. Patients need to be recalled, temporarily close theaters, form a multidisciplinary team, preferably someone external who will be able to find our blind spots, consisting of microbiologists, epidemiologists, if possible, have a timeline and information of all the cases documented, review all processes, all surgical processes, the systemic processes, sterility processes, take appropriate cultures. The importance of a good vitreous sample and a good microbiological diagnosis is paramount, because unless you know what is causing the problem, you will be just shooting in the dark when you're looking for the cause. And of course, informing all concerned, the authorities, the DBCS of your district, and sometimes even the societies when an outbreak is occurring. For smaller hospitals, it is also important to talk to your other hospitals to see if similar cases are occurring so that you can pick up a trend. Obviously, microbiology needs to be done for all the potential sources and the patient. But if you get the same organism from 2 places, then we have molecular techniques to actually help confirm if these were from the same source. So this is a case study when 20 isolates from a hospital which had an outbreak were sent to our microbiology department, and we were able to determine that it was the same organism using molecular technique. So this is helpful not just in finding the source and eliminating it, but it also is a safeguard to surgeons and to institutions. Its investigation is not just about microbiology. We need to look at our processes. This study by Bayard et al. Showed that there were actually 24 points from the time a patient enters the hospital to getting discharged where you could have a potential source of infection. So you need to see the processes, look at the microbiology, and then come up with a plan. So this is an example of when in 2007, we had 2 cases of Pseudomonas endophthalmitis over 4 days. The vitreous tap and the ringer lactate, which was used then, grew the same organism with the same sensitivity pattern. However, when we did the culture for the batch of fluid, it was sterile. So it was deduced that the contamination probably occurred during IV bottle handling. And in those days, we were still using antibiotic and adrenaline in the fluid, and that led to a change in practice of stopping that and reviewing our hand hygiene processes. So when you have a cluster, you should come up with something like this, information about all your cases. And looking at this, then you will be able to find clusters or find commonalities, which will help you further in the investigation. But for this to occur, there needs to be a continuous surveillance and documentation. This does not need to be filled for each patient, only for the patients with suspected end-off or TAS, but the source of these data points needs to be there in your system so that they can be collected and documented and proper sense made out of what we have done so that our investigation is focused. I will end with a few other essentials which we need. Very important to communicate in larger hospitals with your colleagues, with other units, with your societies, as well as in other countries, they also have registries, which are very, very important. A heightened awareness and quick response is very important. A lot of eyes have been saved when patients were actually picked up during evening rounds because they had symptoms which were out of the ordinary. I've already spoken about recording and documentation. These are just some pictures of what are the things we record, like records of the OT air, the regular surveillance, the changing of the sterility indicators, etc., and continuous training of your existing and new staff so that no protocols are broken. Thank you very much.
Thank you, Dr. Anika, for summarizing about trust and ophthalmitis and how to go about investigating the same. Can I request Dr. Taraprasad Das to also join me on the dais? He's actually the co-chair, so he should be actually heading the show. The next speaker is Dr. Harpreet Kaur, Dr. Harpreet Kapoor. She's the eye health advisor for the CBM for Asia, and she'll be discussing on the OT best practices, checklists, and beyond.
Okay, yeah, thank you. And very good morning to all, and thank you, Anika, for giving a very comprehensive overview of cluster endophthalmitis and the medical approach which we need to take in case such an unfortunate event occurs. So I'll be touching upon some of the standard protocols and the safe practices which need to be followed so as to avoid such an event. Uh, Now there has been growing evidence regarding sources of infection. There is published literature available, and one of these, a systematic review by Park et al. Recently was published in JCRS, and it did kind of identify the cause of the organism, which was which was responsible for the cluster outbreak. And amongst those, intraocular solutions were one of the most common causes identified. And besides that, operating room environment, surgical instruments, and a couple of studies also reported contaminated topical anesthetic eye drops, IULs, and cotton wool swabs as well. So we'll just like to start with the OT complex layout. It is very important that our OT should be scientifically planned and adequate barriers exist between the sterile and the non-sterile areas. So clear out, barricades between outer zone, clean zone, aseptic zone, and disposal zone should be there. Ideally, OT should be in the upper floors and away from the IPD, OPD areas or any other area of potential source of infection. Of course, I mean, we might have a setup which is already there, but in case, this is just in case you have the opportunity to be planning a new OT. So it's good to sit with the architect also to plan it scientifically so that at least the airborne infection and the, because certain areas wherein uh, these staff can be kind of just roaming around, normal general public can walk into the OTs. There are various instances we've seen that such things can also lead to infections. And coming to the operating room, the OT as such, the OR should have an impervious, seamless walls with the floors should also not be made of certain tiles with a lot of grooves in there. And it's ideal to have vertical laminar flow and HEPA filters installed in the OT, which would help in improving and decreasing the airborne infection rate. And of course, all of us might not have a good setup, not good, I would say, a modular OT, or there are areas where sometimes when we work, we have a low resource setting there. So in that case, at least safe practices and building a culture of safe practices amongst the staff goes a long way in preventing such outbreaks. So in the OT, for the OT as such, keep the OT doors closed, restrict the number of personnel in the OT, and especially people with active infection should not be allowed in. Then fumigation and surface infection is absolutely important to kind of ensure that the airborne infection is minimized. And standardized solutions which are available should be used for this. Bacillocid special is one of the common ones being used, which is glutaraldehyde based, and then there are some others like bacillol, which is ethanol based, and hydroxyl peroxide as well. As for the surgical instruments, a rigorous sterilization protocol has to be in place for sterilizing instruments, because that is also one of the major causes leading to an outbreak. So autoclaving, as we all know, is the gold standard, and of course ETO for certain instruments. And in a high volume setup, it's mandatory to have a new instrument, not new, I would say you should have several instrument sets so that they can be autoclaved in between cases. So have so many so that you don't have to use instrument sets by just dipping in some solution or something like that. So, and besides the autoclaving process or the sterilization process, it is also mandatory to monitor the sterilization with chemical and biological indicators, and record keeping is utmost. Patient hygiene, that is yet another factor which can lead to to infections at times. So it is important to educate our patients also regarding hygiene, and patients should be kind of should change and wear disposable shoes covers, so that before they enter the OT, they are not bringing in the infection inside. And then again, besides patient, the staff uh, protocols for staff is also absolutely essential to ensure a safe environment for surgery. Coming to scrubbing, well, it's ideal to have a steel prefabricated scrubbing area with all the important information also displayed, and should have a clock as well with a minute handle. And as for the scrubbing technique, that is again very important. So training, retraining of staff needs to be done so as to ensure that the scrubbing technique is appropriate. Hands should not be kind of dangling down while you are scrubbing. Things like having a wearing all these rings or some bands, even if they are religious, they won't protect you from infection. So they need to be out before you go in for scrubbing. So again, staff training, retraining is important for that. Drapes and packs do create a barrier between the environment and the surgical field. So it's very important to take due precautions while you are gowning. Your mask, your mask should be covering the nose importantly. And in case you don't have you don't have access to disposable gowns, or they are turning out to be too expensive, wear a plastic apron beneath the gown, the sterile gown, the cloth gown, which are made in-house. And then regarding the opening sterile packs, that's the technique of doing that is also very important. Some of these things are very basic, and we assume that the person who's kind of assisting us would know, but like I said, training, retraining is very important to ensure that all the staff members do kind of practice take care of these techniques and have a safe practice there. Okay, so WHO had come up with a surgical safety checklist for all types of surgeries, general surgeries. So these can be adapted. So AAO has adapted for eye surgery as well. So surgical safety checklist kind of just ensures that all concerns regarding patient safety are in place before giving anesthesia. For us, of course, topical is the most commonly used, and then before the incision and before leaving the operating room as well. Intraocular solutions, as we know, have been the main culprit for causing infections and especially outbreaks. So it is very important that we take care of and look into details of all the solutions which are being used. So the batches should be kind of looked into, and a record of that is important. Coming to the irrigating fluid, which is one of the most common causes again. So it's good to use a flexible pouch or glass bottles, and before you start the surgery, the staff should be trained to physically inspect the fluid bottle against light. And bottles should be preserved for say 24 hours odd, and batch numbers of all the consumables should be very meticulously recorded. Documentation, importance of this cannot be overemphasized. It starts with the consent form also. So patients should be aware of the surgery, the associated risks. It should be in local language and signed. And you could create a checklist, a patient safety checklist in your own institution, which kind of one sheet which documents all the pre-op features, the risk factors which could be there. Say patient is on antiplatelet drugs, things like that. And record keeping, like I said, is absolutely essential. Thank you.
Any questions we'll take later on at panel discussion time. Okay. Can I now invite Dr. Hema Joshi from Gomawai Netralaya Nimach to talk to us on current management of endophthalmitis. Dr. Joshi.
Good morning, everyone, seniors and friends. Thank you, Vision 2020, for giving me the opportunity to do this talk. I will be taking up endophthalmitis, current clinical management. The main components of postoperative endophthalmitis care are infection control, removal of inflammatory debris from the vitreous cavity, and to block the inflammatory cascade and its effects on the retina, to treat the complications of infection, to minimize future complications whether from the infection or from treatment itself, and to prevent further episodes. The mainstay of infection control in infective endophthalmitis is antibiotics via various routes and vitrectomy. The most effective route of antibiotic administration is intravitreal, as it achieves high concentration of drug in the vitreous cavity. Initially, Payman et al. Suggested the use of cefazolin for gram-positive foci and aminoglycosides for gram-negative bacilli. Currently, the preferred empirical antimicrobials are glycopeptides, beta-lactam antibiotics, and voriconazole. Specifically coming to bacterial coverage, spectrum and sensitivities support the empiric use of vancomycin for gram-positive bacteria and ceftazidime for gram-negative bacteria. In situations where there is a partial response to intravitreal antibiotics with decrease or resolution of hypopyon and improvement of fundus glow, further injections are not required and medical management is continued. The EVS recommended re-injection if infection is worsening 36 to 60 hours after first injection. But decision to re-inject shouldn't be taken lightly, since repeated injections increase the risk of retinal toxicity. Also, biofilm production and sequestration by bacteria can cause reduced response to antibiotics. Large number of newer studies recommend that if there is worsening 48 hours after the first injection, the patient has to be taken up for vitrectomy. There are several complications of intravitreal antibiotics, including corneal opacification, retinal toxicity, and macular infarction, hemorrhagic occlusive retinal vasculitis associated with vancomycin injection, etc. Use of systemic antibiotics is controversial as most of the drugs have poor ocular penetration. EVS concluded that use of systemic antibiotics does not affect the final visual outcome. The newer drugs like meropenem, linezolid, and fourth generation fluoroquinolones are documented to have achieved therapeutic levels in vitreous and thus can be used. Coming to local antibiotics, topical or subconjunctival, a combination of two local antibiotics is preferred during initial presentation, one for gram-positive and one for gram-negative. CVS recommends vancomycin and amikacin for gram-positive and gram-negative respectively. Once the antibiotic sensitivity is determined, targeted intervention can be done. Coming to the antifungals have never been considered as primary care in sporadic endophthalmitis because of lower incidence. But in places with less rigorous surgical environment, voriconazole is added along with ceftazidime and vancomycin. In case of culture or smear confirmed fungal endophthalmitis, intravitreal voriconazole or amphotericin B is given with or without vitrectomy. Coming to the vitrectomy, it has several advantages over conservative therapy. It improves retinal oxygenation, reduces inflammatory load within the eye, provides specimen for diagnostic evaluation, allows direct inspection of retina, reduces the load of infection, reduces severity of disease, and accelerates visual rehabilitation. There are actually two schools of thought regarding timing of vitrectomy in endophthalmitis. One is based on EVS and another on complete and early vitrectomy for endophthalmitis study. EVS concluded that early vitrectomy was only beneficial in patients with visual acuity of perception of light or worse, that is, the most severe cases. Hence, delaying vitrectomy has become a norm for patients with better presenting vision. However, results of EVS do not really reflect the modern practices and methods. Also, EVS recommended removal of only cortical vitreous. The separation of posterior hyaloid and complete vitrectomy were avoided. Kuhn et al. In a large case series advocated early and complete vitrectomy, including removal of posterior vitreous to remove toxic load and inflammatory debris and to prevent exudates from settling on the macula. With advent of microsurgical vitrectomy, more and more surgeons are preferring early vitrectomy nowadays. Coming to the inflammation control, inflammation plays a huge role in pathogenesis of endophthalmitis. EVS used oral corticosteroid 1 milligram per kg of body weight a day after the intravitreal antibiotics were started, and intravitreal corticosteroid was not a part of EVS protocol. But intravitreal steroids, several Indian studies have recommended and shown that intravitreal dexamethasone reduces inflammation faster, but again, it does not significantly affect the final visual outcome. Cycloplegic agents are essential part of treatment that relieves ciliary spasms and prevent synechia formation in patients with elevated intraocular pressure. Oral and topical anti-glaucoma medication has to be added. Hypertonic saline may be needed in cases of severe corneal edema. Coming to the part of infection prevention, The current strategy of infection prevention is directed to the patient's conjunctival flora as much as controlling the environment and medical supply. The single most effective prophylaxis includes preoperative application of 5% povidone iodine solution to conjunctival surface and cul-de-sac. Bacteria has not yet developed resistance to the povidone iodine solution. Also, few viruses and many fungi are sensitive to povidone iodine. Other measures include preoperatively checking for lid infections, checking the patency of nasolacrimal duct, intracameral antibiotics at the end of the surgery, prompt repair of conjunctival erosions, and suturing any potential wound leak. Use of intracameral antibiotics again remain a controversial topic. The ESCRS recommended routine use of intracameral cefuroxime, but a large study conducted in Irvine Eye Care System on 2 million eyes undergoing cataract surgery showed that intracameral moxifloxacin reduced the incidence of endophthalmitis. But many other studies did not find compelling reasons to recommend routine and indiscriminate use of intracameral cefuroxime or moxifloxacin. One could consider use of intracameral antibiotics in high-risk situations such as one-eyed patients, diabetics, prolonged and complicated surgeries with vitreous loss, very elderly patients, and immunocompromised patients. Endophthalmitis needs to be differentiated mainly from toxic anterior segment syndrome. Other differentials include posteriorly dislocated lens matter, fibrinous reaction, phacoanaphylaxis, and various posterior and panuveitis syndromes. Toxic anterior segment syndrome is an acute inflammatory condition presenting within 24 hours of surgery with a severe anterior chamber reaction, limbus to limbus corneal edema, but there is no adnexal involvement and the patient responds dramatically to the steroids. Coming to the novel treatments, Nakashizuka et al. Reported the safety and efficacy of 1.25% povidone iodine intravitreal injection followed by vitrectomy using 0.025% irrigation to treat endophthalmitis. Most of the cases resolved rapidly, good vision was restored, and no adverse effect was reported. The ERG results also suggested the functional improvement in inner retinal and outer layers after surgery. Microdevices, these are the experimental treatments. Microdevices such as biomimetic nanosponge are being tested to treat endophthalmitis caused by virulent pathogens such as Enterococcus faecalis. Lagro et al. Hypothesized that a biomimetic nanosponge which imitates erythrocytes could absorb subunits of cytolysine and decrease damage to the retina, preserving vision in endophthalmitis patients. My take-home message will be maintain a high level of suspicion in all cases, treat quickly and aggressively, start empirical therapy without waiting for culture results, and in case of cluster endophthalmitis, it's better to go for early vitrectomy rather than intravitreal antibiotics and waiting for the culture results. Thank you.
Thanks, Dr. Hema, for kind of comprehensively covering all the treatment guidelines and also the diagnosis, differential diagnosis, and even some of the novel modes of treatment, which I was really not aware of. I mean, it's good to hear all of that from you. Thanks a lot. We'll bring some of this during the panel discussion. Thank you. Next, I call upon Professor Pravin Vashist. He is a professor of community ophthalmology at Dr. R.P. Center. He is a well-known person in the community ophthalmology area and has done a lot of work for the last 20 years. And he is behind conducting the recent RAP survey across the country in a record time and bringing out all the data to, it's really good to understand where we are now after about 25 years of work. And he's going to talk about the National Program of Control of Blindness guidelines for cataract surgery.
Thank you so much, sir. I am really thankful to Scientific Committee of Vision 2020. They have selected me for this topic, but I am not sure whether I'll be able to justify it because I am not a clinician, never been OT, but still I would like to justify about the guidelines related to cataract surgery and PCB guidelines. In fact, I would like to take you back in 1986-89 survey when we found that cataract is responsible for 80% of blindness. And at that time, it was mainly the outreach camp approach was promoted in country. But in 2001 survey, it was found that nearly 33% of patients who were operated in outreach camps, they were blind after cataract surgery. So at that time, Government of India, they had these guidelines called cataract reach-in approach, where screening camps can be conducted outside, but surgery has to be done in base hospital. Unfortunately, health is a state issue. Some of the states, I remember Jharkhand and Haryana, they're still promoting eye camps. And I have heard that in Tamil Nadu, some people are conducting outreach camps. So still it is in process. Currently, country is going towards cataract blindness backlog free initiatives. And under that, we have taken initiative 2.7 crore surgeries in 3 years. That means we are thinking of high volume surgeries in country. And if we see, it is not only endophthalmitis. If you see visual outcome after cataract surgery, as per the recent survey, 10.9% of the country surgeries having poor visual outcome, that is less than 6 by 60. If we are performing nearly 70 lakh surgeries per year, then 7 lakh people, they have poor visual outcome. And one of the important reason is operative complications, which is responsible for 31.2% of this. That means nearly 2-3 lakhs people, they have visual outcome because of the cataract surgical complication related to operation theater. Whether NPCB guidelines are there for cataract surgery or not, in fact, a lot of people are not aware. Recently, there were some outbreaks, and at that time, even Dr. Namta Sharma, she asked me whether NPCB guidelines are there or not. But I'm happy to say that NPCB guidelines are there. They are formed in 2016, and Dr. Ravindran himself is part of that committee actually. And these guidelines are related to preoperative, operative, and postoperative precautions. As far as preoperative precautions are concerned, they are related to patient screening, the general examination. They said that should be conducted camps. Whenever screening is to be done, it has to be done one day before the scheduled date of surgery. And there should be thorough checkup of BP, blood sugar, and ECG for cardiac and hypertensive patients. And plus urine examination also. And we should look for systemic illness, and it has been suggested that all high risk patient, including patient with uncontrolled systemic illnesses, should not be enrolled for surgery if you are looking for high bulk, high volume surgeries. For related to ocular examination and in pre-operative precautions, they said one-eyed people should be taken, a special precaution should be taken care of one-eyed people, and intraocular pressure along with other investigations to be done. They said for nasolacrimal duct and negative regurgitation tests should be conducted, and in case there is issues, then these patients should not be enrolled for cataract surgery. Syringes should not be done on day of surgery. In fact, all the investigation should be done one day prior to surgeries. And in case of adnexal infections, systemic antibiotics should be given. And if other diseases are there like entropion trichiasis, decrocystitis, they should be treated first. And it has been recommended that there should be a gap of at least 3 weeks after these surgeries if somebody need to perform cataract surgeries. In fact, Dr. Harpreet has given very nicely, my session is easy. She has covered most of the things. As she has mentioned, there are four zones for operation theaters, and each level has to be taken care of. In fact, the level 3, the aseptic zone is the most important one. It should be totally sterile. It should be fumigated. UV light is suggested at night. Floor wall surfaces to be scrubbed and carbolized, and OT must be air conditioned. So these are specific for level 3 aseptic zones. And the second component is the precautions in operation theater. They are mainly related to sterilization of OT instruments and consumables, sterilization of instruments in between the surgeries, documentation process for sterilization, and for surgical supplies like irrigating solutions, ocular viscoelastic devices, etc. So these are certain specific detailed information has been given that the surgical instruments and required linen must be autoclaved using long sterilization cycle. The nurses and doctors, they must ensure functioning of sterilizations. They said for high volume surgery, minimum 4-5 sets or trays per OT should be autoclaved and should be available. And different things have been added. I think there's no need to go into detail of each and everything. In fact, for instruments, they said chemical sterilization should be strictly avoided, the glucurohydride and acetones. You should use high-speed sterilization or flash autoclave for sterilization of surgical instruments in between the cases. And for phacoemulsification, the phaco needles for every 5 Ks, and sleeves and irrigation aspirations handpiece for every case should be sterilized. Documentation, Dr. Harpreet has mentioned, in fact, they have given guidelines related to documentation of sterilization process. For intraocular irrigation solution, probably they are one of the important cause of endophthalmitis. They said both ringer lactase or BSS can be used, but package should be either flexible bags or in bottles. And they should be rechecked. If there are any visible suspended particles or any leaks, they should be discarded. Any leftover solution should be discarded at the end of the day after the surgeries and should not be stored for use or reuse on next day. For surgical supplies, they said should avoid OVD in plastic disposable syringes. Either use glass syringes or glass vials. And for any intraocular injections, including trypan blue, diaphragm in the glass vial can be used multiple times, but on the same day. But any leftover solution should be discarded after the surgeries and should never be stored for reuse. They have given some specific guidelines about patient preparations on the day of surgery, scrubbing and gowning, cleaning and wrapping, and also during the surgeries. The topical antibiotic should be used before and after surgery, and you know, just pre-operatively, the preocular skin should be cleaned with povidone iodine's 10% solution. People are used to dilute it. It is recommended 10% iodine solution should be used. Scrubbing and gowning, the surgeon should perform 3 scrubs with the solution equivalent to 4% chlorhexidine gluconate for at least 3 to 5 minutes under tested running water. And as Dr. Harpreet mentioned, the clock should be available in that area so that they can actually see the time, and should be in methodical manner for distal to proximal areas. Guidelines for clean and draping of patients are specified. Then even during surgeries, about use of some subconjunctival injections, a gloves change, separate surgical set for all patients, intraocular instruments, OT timings, everything has been specified in details. Operatively also about like number of follow-ups, there should be 3 follow-ups, day 1, day 7, and after 30 to 45 days. And in case there should be a, like in some specific signs and symptoms are there, then immediate referral facility should be available for such patients. One important thing has been suggested about the waste disposal, that all the doctors and staff, they should trained in biomedical waste management. In fact, these guidelines has been given as a summary in 2-page summaries there, which the NPCP says has to be circulated in all the hospitals. This is the 2-page summary. And also in the summary, they have also given details about specific points to be remembered during pre-operative, operative precautions, and post-operative precautions. Thank you very much. Thank you.
The last talk in this formal presentations would be by Dr. Kaushik Murali, President, Medical Administration, Quality and Education at Shankara Eye Foundation, India. He's going to talk to us on the reputational management in a crisis. Dr. Murali.
Thank you, sir. Can the slides come up, please? So whatever you do, at some point in time, we would be faced with some kind of an uncertainty. And reputation is something that has stood time. So this is a quote as early as from Socrates, who said that to gain a good reputation is to endeavor to be what you desire to appear. And each one of us as a large hospital or an institution or even as an ophthalmologist are very particular about how the world perceives us, and reputation becomes very critical. Time and again we see these reports where our colleagues are kind of flung into the mud, so to speak, where words like botched up typically get used or negligence gets showed up. And there is very little analysis that is done, but it is more like the instant kind of an attention, and very often the damage is done very, very early. Most of these subsequently they would find a source of infection that probably is not attributable to the hospital or the doctor, but these media channels very rarely go back and kind of recorrect what they have shared. Now, for any institution or for anybody, there are two things of critical importance: the trust and reputation that we enjoy. Uh, Again, Philip Kotler, who's one of the management gurus, has shared that reputation is very hard and time consuming to build. And therefore, it is very critical that this is something that we walk the talk. So it's not something that you look at only at a time of a crisis, but the behavior of the institution should be towards this, so that there is some amount of reputation that is inherently built. How does this impact if it gets hurt? The recruitment of people becomes very, very difficult. Retaining people is very difficult. Attracting patients is very difficult. We've seen institutions go through a turmoil. Some have been asked to even shut down. Uh, this also becomes very critical because if you have an inherent good reputation, the negative effect to some extent could be mitigated. And again, a lot of us are not for profit. We are dependent on some amount of contributions and donations coming in. It does not only affect the fund flow coming from the patients, but also donations come down. And this has been reported pretty much from across the world. Uh, Crisis is very, very immediate, and this can have a very long-term kind of an impact. And most often we need to be clear that this can come through varied means. It can come from media, word of mouth, other publications that patients can have access to. When you look at the entire ecosystem, there are multiple players involved. So you have the government, the media, the society at large, public interest groups. Apart from that, we interact almost on a day-to-day basis with our own employees, our patients, our customers, our suppliers, and people who probably fund or contribute towards it, who form the board. And it is very important for us to see where information is flowing, because the reputation could be impacted by any one of these stakeholders in the ecosystem. Now, just to take an example of Maggie, this is something all of us love. I can stick my neck out and say that all of us have had it at least once, if not more. 2015 May, they had about 98% of consumer trust. They were selling about 15,000 tons of Maggie in India. October 2015, there was a report that came out saying that there was levels of monosodium glutamate as well as lead in it, and it dropped down to 0 tons. This happened in a time frame of about 4 to 5 months. And of course, the nation wanted to know what was happening, and all the media channels literally had a field day with it. What happened essentially was they neglected public opinion. It was a fiasco to start off with. They argued saying that testing is not appropriate, reagents are very expensive, most labs don't have it, therefore it is inaccurate, and that they were very factual, saying that we've tested 3,500 samples, but they just ignored the public sentiment, which looked at public safety. Second is they were really slow. They waited for almost about 19,000 odd mentions on social media before the first tweet. There was just one tweet from Nestle in May, which kind of very vaguely spoke about saying, yes, we understand and we are there for you, and nothing has been recalled. They pretty much denied the entire problem even happening. So this was perceived as being arrogant because they confronted not just the customers, but also the regulators. They did not have a crisis management at that point in place. They overlooked the entire cultural factors because Nestle was still perceived to be a multinational company, therefore a foreign entity. So it became a us versus them kind of an interaction. And they were traditionally, being a European company, they were very, very media shy. So they did not engage with media as a habit. This resulted in the then CEO being asked to step down, and Mr. Suresh Narayan, who was heading Nestle in Philippines, was called back. And what he did was a threefold activity. One, he started communicating. He put it out there, spoke to people, set up a 24/7 consumer engagement where people could talk about it. They encouraged consumers who were using it to come back. They came up with a campaign called We Love You Too. Uh, they looked at what they knew and what they were doing. And they actually took back almost 35,000 tons of supply from their stockists across the country. And it probably is the largest logistical activity that was done. Very quickly, they turned around. And these are some of the learnings even for us. Often there is a lack of information. uh, that commonly happens. You lose control of the narratives, rumors are flying around, things escalate, videos are shared, not necessarily from the current context, but could be from the past. There is intense public scrutiny and you will face hostile questions. The minute that happens, the tendency is to go defensive or to blame somebody else. What we need to look at is to be proactive and form a strategy that looks at our current identity, how are we building it. You need to have some kind of a self-presentation. You can't just put it out there saying, oh, you know what, we are empathetic, and not be that in your day-to-day job, because then that's going to make a big difference, and you need to keep measuring this. This is quite easily done looking at today's social media penetration, that you can find out how the rest of the world is reputing you. Uh, Again, it is very critical that whenever there is a media report adverse, that there is a response. You cannot shy away from that response. And with the development of internet and social media, the time to response has today come down very, very much. What should be a good plan? You need to designate specific members. You need to have checklists of various scenarios. You need to practice it out, and you need to keep updating it. So during COVID, we came up with a kind of a crisis plan saying that who will talk, what happens if there's an outbreak, what if somebody asks you to shut down. So this becomes very critical because this is a very dynamic situation. It is always a good idea to have a public relations firm engaged, because they generally have those inroads into media who would be willing to carry your side of the story, and they can also train the doctors in terms of what should be spoken, because we don't know how to talk, because we are very, very there is an asymmetry in the way we engage with patients, and we tend to engage with everybody in that same kind of a demeanor. Never speculate, try to be as transparent as possible, don't be defensive, and never ever say no comment, because that pretty much implies that you're taking on the blame for what is being happening. How do you know what information you're putting out, whether it is correct or not? One, would that be something that a responsible person would do? Would silence be seen as a sign of guilt? And are others already framing the story? So these three will kind of give you that cue of saying that should you respond or can you take a little bit of time? You don't have to be trigger happy. Uh, Again, critical for your team inward to be on the same page, because when people hear varying stories, they feel it is disorganized and untrustworthy. So you cannot have a plan in place where your staff just goes and shoots off the hip instead of what you've agreed on, because you would never know today who's recording what you're going to talk. So that is very, very important. Being sensitive is very critical. Uh, it is a very emotional period from the patient, their family, from the regulators that are there. Transparency is very good. But again, it is important to put out the holistic picture. It is good to get some fraternity colleagues to get into the picture and talk on your behalf. Let them know what has happened so that they have your back and they can actually put out a narrative that is the whole truth and not just the bad part that is happening. And very important again to be acting in real time to provide accurate information, and you need to see how you can avoid any damage control. To summarize, it is important for us to take responsibility. Outbreaks have happened. We probably have some aspect of it. Covering it up will only worsen the damage when it comes out. There is a need to put action, acknowledge it, accept, apologize. That becomes very, very important. And no, don't add fuel to the fire by ignoring it or being very aggressive with them. You have to be ready for a social media backlash. Uh, how are you kind of controlling it? How are you responding to it becomes very important. Are there spikes of negativity? You need to have a plan in place. You need to understand the situation. Like I mentioned, no comment will not work. Even if you're assessing the situation and you don't have the complete picture, you need to say that, saying that we're testing our samples, we are finding out what's happening, we invited other institutions to come inspect our facility. Whatever is there becomes very, very important. Don't be knee-jerk, that is very, very critical. Again, important for us to put in the shoes of our own patients and say that, how would I feel if it happened to me? And how do we ensure that we do the right thing? So with that, hopefully we will have a little bit more of method to the madness when we are in this time of very adverse kind of a situation. Hopefully none of us will have to be, but this is akin to getting a heart attack and we need to be careful there. Thank you.
With this, we end the 5 formal talks. Can I request Dr. Padma Pal to take over for the moderating the panel? I'm sure the questions arising out of these 5 talks will be also covered in the panel discussion, so we're not having a separate question answer session. Am I right, Dr. Padma? Yeah.
all the topics very comprehensively. At this point, I would like to thank Vision 2020 for taking this up because it is very often under the carpet. As we start this panel, could I request the other panelists also to join us? Dr. Thomas Kurian, Dr. Thomas Cherian, and Dr. Minija. We are very privileged to have experienced ophthalmologists with us today as panelists. Dr. Lingam from Shankar Netralaya, Dr. Tara Prasad from LV Prasad, Dr. Ravindran from the Aravind Eye Care System, Dr. Thomas Cherian from Little Flower Angamali, Dr. Thomas Kuriakose, who's currently in Giridhar but has spent a large part of his career in the Christian Medical College Vellore, and Dr. Minija from the Shankara institutions. Without much ado, we will go on to the panel discussion. We've had an exhaustive session outlining the processes. But if we stop with just outlining the processes and don't review what has happened at the end of it, we are going to make the same mistakes again and again. If we looked at it as an investigation cycle, this has been outlined in great detail. What we will try to do as in this panel discussion is to see how we can map how clusters happen, look at these processes, and finally provide standard operating procedures in such a way that we can bring down the incidence of clusters. At the moment, friends, we do not have enough evidence to manage clusters. What we are working with is evidence towards sporadic endophthalmitis. Firstly, this panel hopes to bring experiences much more than published literature. And secondly, we have a mandate from the Vision 2020 to come up with an SOP which gives us recommendations to say that if this, and this has been done from the side of the institution, there will be backing from the Vision 2020 to make sure that they get the support that they need. As I have mentioned, I will also tell you what they will be contributing towards the panel. Dr. Thomas Cherian is a vitreoretinal surgeon. He has been very gracious to be able to share his experience that he's had with an outbreak way back in 2012. Over to you, sir. Just a minute before we proceed. The way we will do this is about 2 to 3 minutes of sharing, and then I will give you the questions, and we're most welcome for the audience to ask the questions at the end of the panel. Thank you.
Thank you, Padma. We had a cluster endophthalmitis in 2011. In short, let me put the background of Little Flower Hospital. We are a multi-speciality hospital with the major department being ophthalmology for a long time. We have been doing paying and non-paying surgeries, cataracts and all subspecialties over a period of time. In 2000, towards the end of the first decade of this millennium, we were planning to shift to a new facility, and our new building was getting ready. The building was already inaugurated in 2011 November, but there was some work to be completed, so we were planning to shift in 12 January. So we were continuing to work in the old building. We were using the old operating room, and 16th of December, we got one case of endophthalmitis back in our OPD, and we found that it was operated on the 6th of December, that is 10 days following the surgery. We took it as a sporadic case, took up the patient for an intravitreal injection. The vitreous sample was sent for microscopy and culture. Later on, which came as an aspergillus endophthalmitis. This was on December 16th. The next day, December 17th, we got 3 more cases which set off the alarm bell. So that is 3 cases. And in the next 2 days, we got 36 cases coming which were operated on December 6th, 7th and 8th. We got all the cases done from December 6th onwards, And these 36 cases had developed an endophthalmitis. For some unknown reason, this stopped after December 8th. Only those cases which are operated on 3 days had ended up with endophthalmitis. So then we immediately closed down the operating room. We took all these patients according to the severity of the disease, some for intravitreal injection, some for vitrectomy. Finally, I ended up operating 32 cases vitrectomy in 4 days' time, and the other 4 cases we operated, we gave intravitreal injections, and the infection subsided. Out of these 36 cases, we got culture positive for aspergillus in 24 cases. Others, we didn't get a positive culture report. And all these cases, the infection was controlled. 30 cases got back good vision. 2 cases, the eye was saved, and the rest 4 cases went into a phthisis bulbi. So this was the cluster endophthalmitis situation which we faced. We closed down the operating room and we never opened that. And for the next 3 weeks, we didn't operate. Then we shifted in 2012 January to the new operating room. It was an entirely new facility. Now looking back, one or two things which happened during that time. One, there was a construction going on in the campus. That was a major construction. 8-story building was being put up in the campus. That was probably giving a lot of spores in the campus. Second, even more important than that, that was a lapse on our part. The air conditioning in our existing operation room failed. That was in November. Our electricians came and changed to a new AC, but it was not a new air conditioner. He had in fact taken one air conditioner which was being used somewhere else and installed in our operating room, which we overlooked, and it was a lapse. And we had some molds growing in that air conditioner, which we found out later. Okay, so that was our experience with managing endophthalmitis. Now, shall I go into the social part of that? While these cases were in the hospital and all these cases were operated and we didn't discharge them, they were still in the hospital. One morning I was walking into the hospital when suddenly I got a call from our hospital director. Again, the pattern in our hospital, ours is a multi-specialty hospital. The administrators are non-medical individuals. It is run by the church. A priest is in charge. So I got a call from the father director to report to his office. And one of my anterior segment colleagues was also called in there. And father was showing to us in a TV screen in his office a scroll that a lot of cases of cataract operated in Little Flower Hospital had infection and many have lost their eyes. So father asked us to look at that. Then by the time he called us to the room, he had already collected the phone numbers of the people running this particular news channel. And now he told us, yes, there is a news coming up. I'll call the news channel. You please talk to them as to what is being done. Rest of it, I'll talk. Then he handed over the phone to me, and to the news channel reporter, I talked whatever I said now, that this is how we managed and these patients are recovering, and that's all that we have done. This is the explanation which I have to offer. After that, father took the phone and talked to this gentleman. So that is the explanation which we have to give from our part. Now you see for yourself what is our standing in the society, what have we been doing over the years as an institution, what is our contribution to the society. And if you want to break it in 5 minutes, you can do that, but please take a call from your side. And that was it. In 5 minutes, the scroll went off and it never came back. One or two stray incidences of reports came in the newspapers, but that also subsided with that. So that was our experience with managing an endophthalmitis cluster.
Thank you so much, Dr. Thomas. It is not easy to share the experience of a cluster, and we are really grateful that you've been able to do this. A few things that he has been able to bring out. Fungal endophthalmitis does not present immediately, so we do not have the luxury of saying we close theater. By the time you find out, it can take some time and more damage can be done. So the index of suspicion has to be really high. And the other thing, even in published literature, construction activity is a high risk for endophthalmitis occurrence. Perhaps we should look at saying that if you are expecting large construction, should we withhold elective surgeries at least for a few days and prevent ourselves from having to face this? Uh, I would want to ask you, um, what did you feel was the difference between, say, what you did and what is done by some others where they actually, don't face the media, and then the damage that happens out of that?
I didn't get your question.
You handle the media really well. It's very obvious from your illustration. When you don't do that, what are the repercussions that the institution can face?
Next day it might come in the next channel. It will go up in leaps and bounds. This news spreads like flames, and the entire public. Kerala is a very vigilant state. The entire public might turn against the hospital, and there could be violence. There could be all sorts of trouble. This has to be expected. But then again, going back, this was in 2011, which was a pre-social social media era.
So that is so well demonstrated. Early intervention of endophthalmitis with vitrectomies as he needed to do, the conviction that he's doing his best, and the communication that we are doing our best. If you want, you can go ahead and show this on media, but this is what we have done, and the outcomes are there for the speaking. Thank you so much, Dr. Thomas. I would now request Dr. Thomas Kuriakose, who has been involved in teaching for a few decades and has also got experience in setting up mission hospital ophthalmology setups in low resource settings. So if you could briefly tell us your experience, Dr. Thomas. Thank you.
Okay, I will start with the low resource setting first. So I've had the opportunity to sort of restart defunct hospitals, and quite often the problem is how do you handle this restarting of the institution. So one of the last ones was in Kotagiri. So there they had this building, and we had to from my past experience, I realized air was a big problem. Even construction, I think, is related to air quality. And I remember in Vellore, way back in 1992, when HEPA filters were just coming in, and there were no commercial this thing. We had an episode there where we didn't have the filtration at the end point. There were ducts after the HEPA filter because the way the hospital was constructed. And then we had a bout of fungal endophthalmitis, and the reason was the ducts after the HEPA filter was growing fungus. And then that was just spewed all across the operation theater, and we had this bout. So the first thing which I did there was to have HEPA filters. Kotagiri was luckily, it's a cool place, so you don't really need cooling. So what we did there was just put HEPA filters on the window modules instead of air conditioned, and just blew in fresh air from the outside. So that is so you really have to figure out, depending on the situation, and see like what are our needs, and then plan according to that. So air was handled. Then training of the staff. Quite often in low resource settings, we don't have trained personnel. I mean, we have OT helps who are probably not really properly trained nurses, and so they need training. And this is a big problem in all low resource settings. They may be local girls who just called in to be like nurses, and so telling them the importance of cleaning, all that was mentioned earlier on. And the fact that even though the incidences are so low, I mean, sometimes you think, oh, we're operating 100 cases, only one infection, so what's the big deal? So that, that sort of training of attitude is important, that one case out of 100 is too many. So once you say, impress upon this group the importance of, what an endophthalmitis can do, then that's when the training starts, and then the routine training, the importance. So I think sterility, air quality, cleaning, and then the final thing is, while you're assisting, what are the sterile barriers and those sort of things. And of course, constant evaluation of this training. See, doctors, I don't think is a big problem. It's the other support staff training I would concentrate on, especially in a theater setting. Uh, and academics, so if academics do, when we think it's usually on PGs, I think the bigger problem is even in academic settings, you have to understand there's a rapid turnover of nurses, and all those staff are also turned over pretty fast, which we don't realize. So I think they also, so their training becomes very important. So I think this is all I really have to add to this thing. One more thing I just want to mention, in terms of sources of infection in this cluster endophthalmitis, and that was another experience of mine where the problem was actually in the sensors in the phaco machine. The companies will say, no, there is no connection between the fluids and their sensors, but that was not true. And we had an endophthalmitis from Pseudomonas uh, from a phaco machine. Then every so often we used to have endophthalmitis, and we really couldn't figure out what was happening. And then we realized the first endophthalmitis actually had infected the sensor in the, so that sensor system in the machine actually had a sort of connection and a fluid in it, and that fluid was infected with the same Pseudomonas, and our lab confirmed that all these Pseudomonas came from the same source. And so that is another thing people should keep in mind, that the monitoring of these monitoring systems in phacos, is there a connection? How good are those things?
Thank you so much, sir. And continuing on the experience that we've had in Vellore, again under the leadership of our senior faculty there, you would have heard Anika mention how ringer lactate was we added gentamicin and adrenaline. It is not enough to say that unopened bottles are sterile. Unopened bottles may be sterile, but your process may be the culprit. So at the cost of repetition, I'm emphasizing that please review your processes. And how did we do this? We cultured not just unopened bottles, we cultured the open bottles as well. And this is why, even though the biomedical waste says that you have to destroy eliminate used material, we would be legally liable if we do not have them for examination in the chance of an outbreak. Uh, in 2017, we had a cluster, and when we investigated as described, we could not find a cause. However, this has been the thing that you review all your processes, retrain all your staff, and then restart. And as you can see, we have been blessed so far, I should say, that the rates have been low. I would just ask a couple more things from Dr. Thomas. Cost is an issue. How do you balance the fact that we have to do this at the minimum cost and the rest may be fancy? So what are the cost implications in low resource settings?
So, there are other things mentioned in terms of prevention, and one thing I did not notice is use of betadine after the surgery. It has been shown that a lot of the time the source of infection in after cataract surgery is actually the hypotony that is caused after the surgery, and that sucks in bacteria from the flora. So it is a good practice also to use betadine at the end of surgery, so that the cul-de-sac is a little more sterile. So in terms of, injecting moxie at the end of for me, I think it's mainly in the quotes, have you done it? Yes, I've done it. I'm not sure of the value, how much change it really does. But then it's not only about, evidence, it's also about, tomorrow the judges ask, what did you do for, preventing end off? You should say, yes, you should tick a box, especially when it's part of a, recommendation. I think we should do it. And I think when you're doing large volumes, all the more important that whatever the resource setting, I think it's worth it.
Single-use instruments, we have to re-autoclave with costs. Yes. We would have legal backing if we did that.
Sorry?
Single-use instruments which are re-sterilized and used.
So again, I think multiple sets is probably the way to go. and rather than re-sterilizing it, have multiple sets which are sterilized in a proper way rather than come. And I think institutions will slowly realize it's much more worth having multiple sets of instruments rather than you know going at. I think a lot of even the low resource settings, I think people are realizing it's better to have multiple sets, and that's the way I would.
Sure, thanks. Um, I would now invite Dr. R.D. Ravindran, who's not just been involved in the cluster outbreaks in the Arvind Eye Care System, but has been appointed as the external investigator to other institutions which have faced clusters. I would be grateful if you could share your experience with us, sir.
Thanks, Dr. Batma, for involving me in this session. I mean, within Aravind, as you all are aware, we have about 14 hospitals, and currently we do about 2,000 plus surgeries every day. So of that, maybe like 1,600, 1,700 cataracts. There's a large volume that is being done. In the last 40 years, we had at least two instances where we had a cluster. So I'll probably share each of them very briefly. The first time when it happened, we had done close to about 100 plus surgeries on that day. About 7 or 8 people were involved operating. But there were about 8 patients who developed endophthalmitis on that particular day, and all of them belonged to that one doctor. One operating room was involved. Then, when we went into the details, then, when we saw the first patient, we treated it. When the second patient came, then we knew that something is wrong. So everybody who had operated on that particular day were contacted. We asked them to come back to the hospital. Unfortunately, there are only 8 patients, but they all, even some of them, we have to really coax to bring them back, especially operated on that particular theater. So the way we are set up is that each doctor is given 8 sets of instruments. And that particular day, they all undergo a long cycle sterilization. This doctor had done about 4 of that set is for phacoemulsification, rest 4 is for small incision cataract surgery. So the doctor had done about 4 phacoemulsification, and then these sets went for autoclaving. For some reason, I had to go on that particular day to operate on a very senior doctor in the city. So I went and did the 5th surgery, 5th phacoemulsification. Then I came off. Then the doctor continued with the small incision cataract surgery. He did after that 4 phaco, he did plus 20 plus small incision surgeries. So the first 4 he operated, and then the had developed endophthalmitis. The one patient I did after that 4 cases, where I used the instrument that went for flash autoclaving or high-speed autoclaving, didn't develop. The next 4 patients, which he did small incision cataract surgery, developed endophthalmitis. Then after that, none of the patients developed. So this went on to show that the initial sterilization that was done the previous day, that had gone for long cycle sterilization, there was a problem. When we looked at the indicators, it has changed. These were all class 1 indicators. So any temperature that will change. That's what I understood. So from the investigations, we found that that particular theater, that bin was autoclaved the last. And from whatever I could understand later on from the postmortem, saying that that was not fully, probably there has been a compromise by the CSST staff in completing the whole cycle. Okay, so it becomes important that we have to use a set of different indicators, not just the class 1 indicators. Once we moved on to the class 5 indicators, then we were able to pick up even cycles that went through a regular full cycle, but still they were deficient. We were able to pick it up. So this shows two points. One is sterilization, autoclaving is very important. Even if you have kept, unsterilized, here it was poorly sterilized, it was contaminated, the set of instruments on the table, but that table was not contaminated because we were not changed the table. We are using the same table. But the 5th patient, which we had used a re-sterilized set of instruments, and later the other 15 surgeries that were again reused with the same table did not develop any endophthalmitis. So I think sterilization is really probably the key thing. Probably the next thing may be the supplies. And again, this is the second instance where we had close to about 20 patients developing endophthalmitis. Here, the doctor had done close to 40 surgeries. On one table, he did only phacoemulsification. Other table, he did only SICS. Only on the table where he did phacoemulsification, developed endophthalmitis. On the other side, where he did SICS, did not develop. And here again, there are like on the side where he did SICS, there are two patients. He had used this irrigation from the machine, phaco machine, to do the irrigation aspiration. They developed. So that went on to show that the tubings were a problem, and then we really understood. ETO, as much as the cleaning, the drying is also very important. And again, that was last day we started. No, we decided to dispose any of the tubings. No, we will not do ETO. Either we'll buy tubings which can be autoclaved, or we'll go for fresh tubing. So once we made that change, because my ETO also you have to be very careful, because the indicator before and after is very difficult to see whether it has been sterilized. So and here again, moving towards adding other indicators. The newer, recently I think the ETO also got other process indicators have come. Using that also becomes important. So as far as going out, going out is more for a postmortem. Going out, they call you after 1 month or 2 months, not immediately. And there you cannot say anything, but most of the time you go there, understand how they were doing the sterilization, and put in place best practices and come back. That's the best we can do. Because if you really want to track what is going wrong, so a lot of discipline have to be in the system, especially charting the series of the patient, the way they have been operated. Who was the first patient? Who's the second patient? Who's the third patient? And then all of us have a habit of operating on two tables, making sure that you don't share between the tables anything. So whatever is on this table should go to that patient. Non-sharing of supplies and keeping a track of the, the, the way they are operated, all that will help. And then again, the documentation of the sterilization. If all that is there, then we can probably do a postmortem to find the reason. If it is not there, it becomes very difficult. Yeah, thank you.
So, thanks so much for sharing, sir. So, when do you think an external investigator should be involved? In your case, you have gone as in a situation where you are trying to restart theaters, perhaps. Would you not advise that in situations where they are from a smaller hospital, they do not have the know-how to do the investigation on their own, we could have a system in place where we could have people who would be appointed and be sent as external investigators?
It definitely be useful now to get somebody from a nearby institution or nearby hospital to come and help them in a friendly manner. But ideally, any doctor who undertakes cataract surgery, I think he has to form a team of people who will take the responsibility for the whole sterilization. Understand, always we have to understand the exceptions in our practice. What can go wrong, and what is it we need to do to make sure that it will not go wrong. And if that something goes wrong, understanding why it went wrong also becomes very important. So having an internal team, being aware of this kind of something like a emergency can happen in our practice, and be prepared for it. And and what is it we should do, so that we'll be able to properly analyze and avoid it. It's always better to take a help. If you're not a big practice, not multiple ophthalmologists are not involved in your practice, I think taking the help of somebody in a nearby institution always really helps. And again, as he said, like these two instances, we had called everybody, every patient. If the patients really understand that we are really taking good care of the patient, of them, they will never go to the press. That's what I have seen.
Thank you so much, sir. I believe Dr. Tara Prasad has to go to another session.
No, no.
Sorry, so shall we just go to Dr. Tara Prasad and then come back?
Continue with that. I have to go to some other place.
So can you do now and go?
No, no, continue. No, don't change your routine.
No, no, sir, we need your input. I will just do it very briefly.
Not fair. I have to go some areas.
Oh, they're waiting? Oh, I'm so sorry, sir. I was not aware of that. Okay, sure. Okay, sure. Thanks. Okay. Okay, thanks. I believe we have crossed our time, so can I just request Dr. Lingam to tell us about the recommendations you would say in terms of treatment outcomes nowadays? How far should we search for organisms, and what would you have to contribute?
First, I thought one point I would like to make is recognizing a cluster. It's not that cluster comes up one fine day. It's scattered over time, and it may take some time before you can collate the data and find that actually something is happening. And this happens very often when there are multiple surgeons involved, multiple locations involved, and it's a big operations like Arvind Eye Care System. Each person may not communicate with another person. One person may have two infections, another person may have one infection another day. So unless there's a common location where all this data is pulled together, there's no way you can make out that something wrong is happening. You would think that's just a sporadic infection. So it's a good practice to have a periodic collection of all infections in an institution and present it to a common forum. And the periodicity would depend upon obviously the size of the operations. The larger the operations, the more frequent the collation of data is important. While if the operations are smaller, you can probably have it monthly rather than very frequent. And this responsibility can be given to the microbiologist because they receive the specimens for processing. They know whether it's an in-house case or an outside case which came, or a post-traumatic case or a post-operative case. Everything is written obviously in the referral form when the specimen is sent to the microbiology laboratory department. So they collate the data, and at the end of the agreed periodicity, they make a presentation that these are the cases, and then they would obviously collect the data on which OT and which surgeon, sequence of the surgery, etc., etc. So all these would also be included in the referral sheet when the specimen is sent to the microbiology. If this is made a routine, an absolute routine practice, cluster can be picked up much earlier, and then you limit the damage. Obviously, cluster infection occurring like a pseudomonas in one day, 20 cases out of which 5 infected, nobody can miss it. It's obviously staring at you. But kind of infection like a fungus infection, which is not that occurs in every case, you require enough bolus to create a clinical infection, and small amount of contamination can get washed away. And these can be infrequent enough to miss as a cluster. And that is where this kind of a reporting would go a long way in picking it up much earlier than later. This is one point I would like to make. And you wanted to tell me about the management, how
Right,
which has
so
changed.
whether vitrectomy is...
Yeah, so technically speaking, management outcome should not change whether it is a cluster infection or a sporadic infection. It's a question of you treat it as an infection at endophthalmitis. Obviously, when it's a cluster infection, your antenna are up. You're already very alert to the possibility of a particular organism which you identified from case 1. So your treatment should be even better than what it would be for a sporadic case because you're already tuned to what organism you're dealing with. So outcome should be actually better considering, of course, the pathogenicity of the organism. And unfortunately, these cluster infections tend to occur with very, very violent organisms like pseudomonas, which can damage the eye in spite of your best efforts. And I don't think there's any difference in the indication as far as intravitreal injections, frequency, the medicants to be involved, or the need for vitrectomy. All these are independent of what your case is. Is it cluster or a sporadic case? I would say the outcome is the same and the treatment approach is the same. I don't think it would be any different.
Thank you so much, sir. Yeah.
One point in a cluster, if you know that it's a cluster, the multiple cases are referred, and usually it's a gram-negative organism, so it's better to give tazobactam for this group. Usually that's how, because these are all resistant to other drugs.
That's exactly what I said. So if you know the organism,
sometimes even they come in a cluster, then taking the culture or a sample, it takes time. So straight away, as a principle, we have been handling few clusters from outside. So now we make it a point to give it.
Oh, yeah. Once you know what the organism is,
it's good. It's easy.
Definitely you inject, no doubt about it. And anyway, we are covering gram-positive, gram-negative spectrum, even in the routine sporadic endophthalmitis. We don't give just vancomycin. We always give along with it these ceftazidime. Yeah, so there's always given. So we are covering definitely both organisms. You're not covering fungus as a routine because that's relatively rare.
So in the interest of time, I would just request Dr. Minija to very briefly tell us what are the risks of prophylactic measures that you take as end of which lead up with TAS?
I know always post surgery we always worried about end of thalmitis before, but now I think so even TAS is an important factor which we have to consider because the visual outcome is so much importance post surgery. I know Arvind Eye Care System has published an intracameral route of antibiotics to prevent the end of thalmitis. But on the other hand, we know that TAS is one more reason where patient can have a decreased vision. Now, the importance of using intracameral antibiotics, what are we using? Because you know that it can have toxins. The pH is very important. The preservatives in the intracameral medicine which we're using. So most of them, I think everybody use off-label, which is not actually for intracameral, but it's for topical use. But I know Orolab has come with the Oromax. Now the thing is, do we use those medicines to prevent the TAS? So that is mainly concerned. And one more thing, I think some of the institutes, when you do in a lot of surgeries, we subconjunctival injection of antibiotics. As sir was telling that, post surgery, the thing can seep into the eye. So all this subconjunctival injections are preservatives. They have it. It can seep into it and cause. So it's very important for us when we use an antibiotics to prevent endophthalmitis, but we know that it can cause something else. So it's very important to look into these factors when we use intracameral antibiotics or subconjunctival antibiotics, as though we know that we are preventing end of what we might think.
Blend up with TAS. Yeah. Unfortunately, in the interest of time, we've not been able to have the contribution that we had asked Dr. Tara Prasad to do. I will just make one point to the panelists. Thank you so much for sharing. Until and unless we have more robust reporting systems, we are all going to be suffering in our individual silos. So from the Vision 2020 platform, we will approach all the panelists and a few other appointed people so that we can come up with a system of reporting where we support smaller organizations, smaller ophthalmologists, handhold in fact if necessary, so that reporting can be made a mandatory thing. I understand that it has political implications, but I think now the media controls what we do. I think it's time that we change it to where ophthalmologists create the evidence we need and we control how we respond to clusters. Thank you so much. I'm really sorry we have overshot, but it's been such a pleasure.